In this video, we are going to discuss the treatment of wet AMD, meaning the presence of CNV in age-related macular degeneration, using anti VEGF intravitreal injections. We have to discuss how the treatment of wet AMD started. You can see in this timeline progress how the treatment developed, starting by laser photocoagulation around 1993 using the macular photocoagulation study data, trying to coagulate by laser the CMV in the center of the macula, preventing its growth in size. And then there was the advent of photodynamic therapy, where the use of verteporfin vigudine, the photoactive dye that causes an inflammation within the vessels of the choroidal neovascularization, which leads to its occlusion and eventually preventing its activity and edema into the retina. However, the results were not so promising. And then the era of anti VEGF medication developed, and we can see how begaptanib was there and the Avastin off-label use was there. But with the launch of ranibizumab and its lots of randomized clinical trials as the Anchor and Marina, we were already seeing patients who increase in visual acuity and start losing the activity of the CMV. However, they required maintenance of the dosage. Over the years, newer VEGF, anti-VEGF medications were developed, like VEGF Trap I, Eylea recently. The studies started with the presence of ranibizumab in around 2006, with the Anchor and Marina studies trying to research the area of using monthly injections in order to control the activity of classic and occult membranes. Dosing regimens within all clinical studies varied a lot. Monthly dosage was the start. However, we thought recently of a bi-monthly dosing regimen. The use of quarterly fixed regimens was also developed, and its results will be discussed in this video. A PRM protocol, injecting when needed, was also thought of, but it has its limitations. Recently, we have come to the conclusion that treat and extend should be the way to go, and this will be explained in this video and the next one. Monthly dosing was in the early trials. Anchor and Marina, where occult or minimally classic CMVs were treated by doses of ranibizumab intravitreally, given every 4 weeks. Also, predominantly classic CMVs were used in the Anchor study in order to see the effect on the classic CMVs of intravitreal injections of the drug. And for the first time, we could see visual gain, meaning patients in occult or classic CMVs gaining vision using these monthly injections over the period of 2 years, and the visual gain was maintained for the whole group. When you compare the Anchor and Marina patients receiving 2 doses of ranibizumab in comparison to the previous modality of treatment, which was verteporfin photodynamic therapy in classic CMVs, and sham actually just watching the patient in occult CMVs, you can see how we compared some drop in vision that may be slowed by photodynamic therapy to gain in vision using anti-VEGF injections intravitreally. But it was a fact that monthly dosing is not sustainable. Neither the patient nor the doctor could tolerate giving an injection every month for life. Patients who were on monthly therapy at first and then switched to other treatment modalities did not maintain the initial visual acuity gain. The algorithm of Pro-Nanata PRN as needed injections was studied also. It meant that the patient is injected until it's dry without any activity, and then you follow the patient up and you re-inject if there's a drop in vision, fluid seen on OCT, activity on fluorescein, or some new hemorrhage in the area of the CMV, which means some new activity. Pronto trial was one of the biggest trials, or the earliest, in order to discuss the PRN protocol. You can see that the patients were followed over 2 years and given injections whenever the activity was regained within the membrane. The results were not so bad. You can see that visual gain was there, and for the period of 2 years, some sort of visual gain was maintained over the 2 years trial. However, if you look at the anatomy, you can see that the initial 4 months had the best anatomical decrease in the edema around the membrane and thickness of the retina. This was not maintained throughout the study, with areas of increased thickening within the study group at certain timeline points. Why? Because some CMVs showed activity. So it was still questionable if we leave the membrane to regain some of its activity and then retreat it when we find activity. Would the patients do well, maintain their gain, or would they lose some of the visual gain at the beginning of the treatment? The Sailor study tried to look into this PRN protocol in depth, using 4,300 subjects randomized in several PRN protocols, and you can see that over the period of 1 year, the PRN protocol was not really maintaining the initial gain in the first 3 months. You always lost a lot of the gain initially gained at the loading dose of any study. Horizon was also an important study trying to look at how the patients behaved after being listed in an initial study with lots of injection like the Marina and Anchor studies. So they were studied for 2 to 3 years after the initial study, where there was much initial visual gain. You can see that starting the PRN protocol after 2 years of monthly injections still showed loss of the initial gain in the 3rd and 4th year, actually ending up in a vision similar to the start of the disease, where the patient was recruited initially in the first study. This was very disappointing. It meant that the PRN protocol does not maintain the initial visual gain. So you always had some loss of visual gain if you leave the disease to regain its activity. You always had to be proactive, try to inject earlier than that. Still, it was a good alternative compared to the pressure of monthly dosing for years, but the visual gain was still superior using monthly injections. The idea of giving fixed dosing regimens like quarterly dosing, meaning you give an injection every 3 months no matter what is the activity seen, even in inactive CMVs. The EXCITE study was the study trying to describe how would this behave in different clinical situations. So patients were randomized to either monthly injections or a quarterly fixed injections, meaning you give initial loading doses of 3 injections and then you skip 2 months and give an injection on the 3rd month, and you maintain doing this in 2 arms of different 2 doses of ranibizumab compared to a fixed monthly injection dosing regimen. Try to see how will this group behave. You can see here that of course the monthly injections protocol gave the highest visual gain. However, using fixed 3 monthly injections did not show loss of the initial visual gain towards baseline, but a much less maintenance of the initial gain, which means that you are not maintaining what you have gained in vision by injecting 3 monthly dosage at the beginning, and this was correlated totally with the anatomy. You can see the dashed line here of monthly dosage with maintenance of the thinning of the retina at the initiation of the trial towards the end of the first year. However, you can see the seesaw pattern of thickness going to thick and then back thinner whenever we inject a 3 monthly dosing regimen timelines. So this means some patients between the doses, in between the 3 months, show activity and thickness within the retina, and this definitely affects the visual gain. How did all the patients behave? Well, we can see that 42% of patients could gain vision and maintain it on a fixed 3 monthly dosing. However, one third of them returned using this fixed 3 monthly dosing to baseline vision, and some patients lost some vision than the initial vision before treatment. So we know the percentage of patients who can go for 3 monthly injections, and it's around 40%.